We'll be switching gears for the next 15 minutes and moving kind of away from the mechanics of CFRD and talking a little bit about the patient perspective. So Zari kind of already reviewed this, so I won't belabor this, but we know that CFRD is associated with multiple health outcomes. Sorry, I have a lot of animations, including pulmonary function, nutritional status. Oh gosh. I'll show you some data later to suggest an association with mental health and quality of life, and then mortality. And I think perhaps, sorry guys, most importantly, I think just to provide the best care we can for our patients, we really have to have an understanding of where they're coming from. So that is my plan for the next 15 minutes to kind of give us an overview. So most of the data we have comes from semi-structured interviews. The first was a study done by Sylvan et al. Through 6 centers in Canada. You can see that they looked at a total of nearly 40 adults and adolescents, some of whom had CFRD and some of whom didn't. They did not specify if their cohort with CFRD were on insulin, and if so, what type of regimen they were on. The next study is a study done by Millington et al. And Andy Kelly's group. This was done in the US. They looked at a total of 10 children, 10 adults, and 10 parents of children with CFRD. And they did specify that they had 3 adult participants and 1 child participant who were on pump therapy. The third study was done by Collins and Reynolds, and it took place across the UK. They looked at only adult participants, so 22 adults. However, some were diagnosed during adolescence. Interestingly, quite a few of the participants were initially put on oral agents and then were transitioned to insulin, such that by the time of the interviews, all but 1 were on insulin therapy. Finally, the study by Dashev et al. Took place in the US. They looked at 10 adolescent and parent pairs, and you can see there that they had 9 participants on injections and 1 on a pump. And I think one of the challenges with the semi-structured interviews is that they lack the ability to adjust for variables that can impact perception. So things like duration of CFRD, whether or not a participant is on insulin, and if so, what type of therapy they may be on. I think one of the strengths, however, is that it allows participants to speak freely about a common set of topics. So what I kind of did in the first portion of the talk is I've tried to summarize the key findings from all 4 articles and kind of place them into different aspects of CFRD. So we'll talk a little bit about baseline knowledge of CFRD. We'll talk very briefly about the screening process. We'll focus on the diagnosis a bit more, talking about kind of the reaction to diagnosis and the adjustment to diagnosis. Talk a bit more about management. And then in the end, I'll show some new studies looking at the psychosocial impact. So what do we know about baseline CFRD knowledge from these semi-structured interviews? So I think the first question is, are individuals even aware of the possibility of developing CFRD? And I was interested to find these results, and we talked a little bit about this earlier. So whereas in the Sylvan et al. Article, their entire cohort was aware of the possibility of developing CFRD, you can see in the remaining 3 studies that only 20 to 50% of individuals were even aware of this as a possibility. Those who are aware of CFRD tend to frame their knowledge of CFRD based on experiences of friends and family members who have other types of diabetes. So for example, in the study by Dashev et al., 40% of adolescents compared their diabetes to other types of diabetes, stating that it runs in the family, or that it's like regular diabetes, or that it's like type 1 or type 2 diabetes. There is a delay. Interestingly, in the study by Sylvan et al., those who did not have CFRD felt that CFRD was no different than other types of diabetes, whereas those who had CFRD felt that their diabetes was different than other types of diabetes, primarily because of the dietary recommendations. As far as perceptions of causes of the CFRD, so you can see that quite a few individuals recognize an association with blood sugar or the pancreas or insulin or even insulin insufficiency. But you can see that some individuals felt that their diabetes occurred because they hadn't been taking care of themselves. You can see that some felt that there was a hereditary predisposition or that eating well was protective. One parent felt that her child was on insulin solely to help with nutrition, not because of CFRD, and then another parent felt that their child's CFRD would have occurred even outside of the context of CF. So I think in addition to kind of a general lack of awareness, there's also a lot of misconceptions about CFRD. So moving on to screening, so the initial data that will be coming up in a minute is data that Swapnil actually presented earlier. So we know that based on the 2019 registry data, there's quite a few people who are eligible for screening who have not undergone screening. And in addition to her survey data, reasons that are cited in the literature include lack of time or appointment availability, lack of symptoms, which I think goes along with her findings, and then fear of needles. And a couple of the articles mentioned this, so I think it's really important to highlight that we should really be viewing the annual screening as an opportunity to, number one, provide education for families and patients, to let them know that while there are some overlaps with other types of diabetes, CFRD is also very different. And then I think just to prepare patients and family for the possibility of developing CFRD, such that if CFRD occurs in the future, it doesn't come as a surprise. And actually in the study by Millington et al., they found that 30% of children and parents felt that the annual screening helped them to kind of warm up to the diagnosis. So moving on to the diagnosis, interestingly, a couple individuals, it'll come in a minute, actually were relieved at the diagnosis because it gave them an explanation for previously unexplained symptoms. But by and far, many reacted negatively, feeling that this was kind of adding to an already very time-consuming, complex regimen. By far, the biggest concern after hearing about the diagnosis was the fear of injections. We also can see this kind of lack of awareness coming up as a theme, as well as lack of professional advice, not understanding the reasoning behind recommendations. We see this kind of more to learn, one more thing, learning to manage CFRD on top of the CF as a concern as well. The adults had particular concerns about potential dietary changes. Adults, more so than children, viewed this as a disruption to their lifestyle. Parents had concerns about the impact of CFRD on their child's CF and fear of complications. And then adolescents, again, we see kind of concerns based on experiences of friends and family with other types of diabetes. So what are some factors that tend to promote adjustment? So older age, living with others and having some support system, and having a structured CF routine are all viewed as factors that promote adjustment. Again, we see kind of being aware of this as a possibility as something that facilitated adjustment, as well as applying coping mechanisms learned from managing CF. You can imagine that those who had improvement in their symptoms also adjusted a little bit quickly, and then those who actually, there were a few that minimized their CFRD compared to their CF, and this was felt to promote adjustment. On the flip side, living alone, not having a support system, being younger and having a more active lifestyle, these folks tended to view the diagnosis as more of a disruption. We see, again, this lack of awareness as a theme. Time constraints, whether it's effort put into managing CF or other life obligations, and then those who tend to not be as concerned about long-term complications was viewed as a barrier. Moving on to management. So we can see factors that tend to promote adherence. So one article specified that their participants who had a life purpose, such as travel, career, or family, tend to worry a little bit more about long-term complications, and this promoted adherence. Those who are able to kind of incorporate CFRD management into their CFR routine was helpful. Again, those who had improvement in symptoms or lung function tended to adhere a little bit more closely. On the flip side, those who had an adverse event that was attributed to their CFRD tended to adhere to recommendations. And then in the adult study, those who were switched from an oral agent to insulin took their diabetes more seriously, and that promoted adherence. I think we can all imagine that factors that impede adherence, the biggest one is forgetting, as well as having lack of concern about complications, people being younger, having a lack of effect. Pain and child resistance was a big one. Difficulty caring for CFRD during an exacerbation, whether it was because of hyperglycemia due to the stressor of their illness or glucocorticoid therapy or lack of time. Again, time constraints we see as a big theme. Those who felt that they weren't prone to hypoglycemia tend not to monitor their glucoses as closely, and then embarrassment treating in public. So whereas many people tended to feel that their CF was something that could be managed at baseline twice a day, at home, CFRD requires attention multiple times throughout the day, and so those who kind of had this embarrassment treating their diabetes in public tended not to adhere as closely to recommendations. So none of these four articles talked about the patient perspective related to diabetes technology. This probably looks familiar from Bryn's talk earlier. So in general, we do see that, based on some of the factors that tend to impede adherence, such as pain or lack of time, we can kind of see a potential role for diabetes technology. And indeed, in the CF community, diabetes technology is viewed favorably. So in particular, I just wanted to point out that many people agreed with the fact that pump and CGM would help make diabetes easier to manage and would help them do less finger sticks and less injections. Oops. And then finally, talking a little bit about the psychosocial impact. So I'll introduce some new studies now. So this was a study done looking at 209 adults, and they were assessing the impact of CFRD on mental health. So they performed multivariate logistic regression, and we can see that there was a significant association between CFRD and depression. We don't see the same pattern with anxiety, but I did think it was interesting that this wasn't clinically significant, that those who were diagnosed with anxiety or depression tended to be diagnosed after the diagnosis of CFRD. So this is only looking at adults, and it's fairly new data in small numbers. But I think that this is something that we really need to look at, both in pediatric patients and adult participants, as well as families. This is data looking at quality of life out of Canada, and you can see that they looked at 180 adults. They broke their group up into those who did not have CFRD, those who were on insulin and had CFRD, and then those who had CFRD not on insulin. And we can see that the treatment burden score is lower, meaning a higher impact in the group who had CFRD and were also treated with insulin. Interestingly, compared to type 1 diabetes, CFRD tends to have less of an impact in the domains of treatment burden and worry about diabetes. So this is data out of the UK looking at 77 adults, and you can see again in the CFRD group that the scores are higher, meaning lower impact compared to the group with type 1 diabetes. And the authors didn't speculate as to reasons why this may be, but I think we can imagine from a treatment impact standpoint, this could be related to whether individuals with CFRD are treated with insulin or what type of regimen they might be on. And we also saw earlier that those who were able to kind of incorporate their CFRD into their CF routine found it helpful, and so this may reduce treatment burden as well. As far as the worry about diabetes, we saw based on the semi-structured interviews that a few people minimized their CFRD compared to their CF, and this may account for the discrepancy between the groups. And then also I think we've heard that there might be a lack of fear about complications, and this could also affect the worry score. So what is our role as providers? I think this came out earlier in Swapnil's talk too. I really think we need to be providing education during annual screening and viewing this as an opportunity. I think there's still questions as to when that education should start and how often it should occur and who should be providing that education, but it sounds like Bryn's group looked at that too, so I think that'll be really interesting to read about. I think multidisciplinary collaboration amongst providers with an understanding in both CF and CFRD is really important. And then really critical, I think, is trying to work with patients and families to develop strategies that are tailored to their unique lifestyle. And by doing this, hopefully we're able to identify ways to kind of reduce treatment burden, whether it's through diabetes technology or helping patients and families to kind of work on ways to incorporate CFRD management into their CF routine. And that's all I have.